This lecture on spasticity is provided to supplement Dan Korkus's and my chapter on spasticity in Yeoman's textbook. I will provide background on the physiology of spasticity, the spinal pathways that are involved, and the changes that occur in the spinal cord. Then I will go on to how the treatment works, and in particular the pharmacokinetics of baclofen and how the surgery should be done, and then to the benefits and hazards of the technique. Neurosurgeons have had a long interest in treating severe spasticity. In the slide, you see a patient with spastic diplegia who's been operated on by Forrester, and this article was published in 1917. He did a posterior rhizotomy in the lumbar area, sparing only one root at a time, and the results are seen on the right side of the slide with the young patient able to walk for the first time without difficulty. The basis for the spasticity that child had was not well understood until electrical activity from the muscles could be recorded. In this slide, you see a movement of a normal subject with the arm going up and then down, and the biceps firing off in a rhythmical way to allow the muscle to bring the arm up, then stopping the firing and the arm falling down to normal position, and the triceps muscle not firing at all. In this recording from a patient who has mild spasticity, you can see a different motor pattern. The patient is still trying to move his arm up or down, and you can see the pattern is not as smooth as in the last slide. The biceps muscle is firing off but barely stops in between the oscillation of the movement of the arm up and down, and the triceps muscle fires off in a strong fashion to bring the arm in the downward direction, something unnecessary when the patient did not have the abnormal firing pattern. This is a patient with severe spasticity, and you can see how disordered the movement is. The patient can still raise the arm and let it go down, but the biceps muscle is firing off very inappropriately. It continues to fire when it shouldn't, and the same is true of the triceps muscle, although it is more rhythmic. Well, there are many definitions of spasticity. The spasticity defined by Weisendanger seems to be a good general way to view the disorder. He emphasizes, as we saw from the previous slides, that there is an altered activity pattern of motor units, and this occurs to certainly central command signals as well as to a response to the sensory input. And this leads to abnormal movements, co-contractions, mass movements, and also abnormal posture. Also, it is important to emphasize that the spasticity is due to a partial or complete loss of supraspinal function, and that results in spasticity over a period of time, often weeks or months, to develop, period. In the chapter, Dan Korkus outlines in great detail the various spinal pathways that become abnormal when spasticity occurs. I would like to simplify these pathways and talk to you about the alpha motor neurons response to stretch. You see in this slide the input to the spinal cord from the stretch sensitive neuron that goes directly to the alpha neuron of the agonist muscle and through an interneuron to a antagonist muscle group that causes inhibition. This diagram from the chapter shows the muscle spindle input to the alpha motor neuron through the interneurons, and also the more important descending influence on the alpha motor neurons from a number of different pathways. It is these pathways which get disrupted that result in spasticity. Baclofen works by presynaptic inhibition. This inhibition is due to a decrease in the excitatory transmitter being released onto the alpha motor neuron. And that decrease is due to a closure of calcium channels near the synapse. The interneuron releases GABA, and that closes the calcium channels. Baclofen works in the same way on those same receptors and closes the calcium intake into the presynaptic area, and therefore the release of the transmitter is lessened and the motor neuron is less excitable. This slide shows in diagrammatic form where the GABA B receptors are in the membrane and how they affect both the calcium and potassium channels. When a GABA B agonist, either GABA or baclofen, is attached to the receptor, the calcium channels are decreased in number and the potassium channels are also closed down to some degree. In any case, the lack of calcium going into the presynaptic area decreases the release of the neurotransmitter that is excitatory to the alpha motor neuron. The GABA A receptors are different, and they decrease intracellular chloride movements. As mentioned earlier, it takes time for spasticity to develop. That is because it is a biological process that requires changes in the synaptic configuration in the spinal cord, and the ultimate result is hyperactivity of the alpha motor neurons. In the acute phase, there is a loss of synaptic input to the spinal cord because of the damage in supraspinal areas. Then synaptic boutons are lost and degenerated, and new ones grow out and become effective. On top of that, there are biochemical changes that change the amount of receptors, and in particular, the GABA B receptors increase in number. This slide shows some experiments that were done a number of years ago to look for changes in the level of GABA B receptors after spinal cord injury. The normal configuration of the receptors is seen in the spinal cord on the right and is in the substantia gelatinosa area. On the left, after there's been a supraspinal injury, the number of receptors dramatically increases. If we looked at 1 week, we wouldn't see such a large change. This emphasizes the slow changes that take place in the chemistry of the spinal cord that makes it susceptible to an agonist like baclofen that can excite these new receptor sites. It explains why baclofen has very little effect on the normal spinal cord and in normal spinal cord physiology, but has a marked increase of effect because of the changes in the synapses of the spinal cord after injury and after biologically they have changed over time. This slide shows the dramatic effects that baclofen can have on the spastic spinal cord. Before the introduction of intrathecal baclofen, you see the muscles in the lower extremity all firing off when the patient willfully tries to push down his foot. The response is long-lasting and inappropriate for the motion. After intrathecal baclofen is given, you see that the abnormal pathways are suppressed and the normal soleus movement can be made on its own. Thus, baclofen seems to suppress only the abnormal pathways, leaving the normal ones that are still available for movement. The key point is that after an injury, it takes time for spasticity to develop. That patients have very different types of spinal cord circuitry, and along with that abnormal circuitry comes an increase in GABA B receptors, and that it is in that setting that an agent like baclofen, which is a GABA B agonist, can have its dramatic effects in treating spasticity. We are now in a position to discuss how intrathecal baclofen works. This therapy employs a drug pump to give the medicine slowly into the spinal subarachnoid space. It thus avoids the blood-brain barrier. Oral baclofen is absorbed well through the stomach and goes into the systemic circulation and distributes to the brain and spinal cord, but only a small amount of it gets through the blood-brain barrier. It is given in 75 to 100 microgram doses, and it works moderately well, but not for severe spasticity. The reason why intrathecal baclofen works is it not only avoids the blood-brain barrier, but it produces a high local spinal cord concentration of baclofen where the increased GABA B receptors have been produced by the spasticity, which of course was caused by an injury to the motor neurons input from higher areas in the brain. This slide shows the response to intrathecal baclofen in the first patient where the dose was given in a patient with severe spasticity. The Ashworth score of this patient was a severe 5, which means the patient was having almost continuous spasms and almost solid rigidity in the lower extremities. This was caused by an injury to the spinal cord that she had in her teenage years, and now 5 years later she had come for therapy, but it was unsuccessful because oral baclofen and other measures could not relieve her spasticity, and she could not get a therapeutic result. What you see in this slide is that after we gave a bolus of 50 micrograms of intrathecal baclofen via a lumbar catheter, that in an hour's time her spasticity went down to 1, which was a normal tone, and it lasted, this effect, for a full 5 hours and then slowly dissipated over time. This slide diagrammatically shows the same effect, but in this I've inverted the spasticity scale so that relief of symptoms in the yellow line is shown as the patient recovers over time following an injection of intrathecal baclofen. We know now that the concentration of intrathecal baclofen around the spinal cord is dissipated with a half-life of about 90 minutes, and that is shown by the orange line. It's interesting here that the relief of spasticity does not occur until the level of baclofen has fallen significantly, and that the spasticity remains in remission for a long period of time when the level of intrathecal baclofen is lowered almost to 0. The question is, what is causing this delay in the response to baclofen? The reason for the slow response to intrathecal baclofen and the overall slow kinetics of this type of delivery is that the interstitial space where the baclofen has to flow is very small. Only 20% of the spinal cord substance is extracellular space, and the extracellular space is irregular, and the diffusion through the space is very slow. So what happens is that the baclofen in the CSF gets to the peel surface, is able to go through the peel surface and then into the extracellular spaces. But it takes many minutes to hours to slowly work its way into the spinal cord, into the substantia gelatinosa area where the abnormal increase in GABA B receptors is found. And likewise, once the baclofen is in, it stays in place for a long period of time before it slowly diffuses out again. In treating patients with any intrathecal drug, it is very important to understand these slow dynamics, and they're created simply by the difference in the way that fluid distributes in the CSF spaces between cells and the free, easier dispersion of the drug in the CSF surrounding the spinal cord. This diagram shows what happens as a drug is introduced into the spinal subarachnoid space through a catheter. First, there is the movement in the intrathecal space, a movement that is caused both by the turnover of CSF as well as the oscillations of the CSF to the cardiac pulsations, and also the changes in CSF flow that occur with breathing, coughing, or straining. Once the drug is moved by these convective forces, the drug has to diffuse into the spinal cord to become effective. Diffusion is a much slower process than convection, where the drug is just brought with the fluid as it goes along. Diffusion takes molecules from a high concentration to a low concentration by random movements, and those random movements have to take place in the narrowed extracellular space to get to the sites where they become effective in decreasing the spasticity by binding onto GABA B receptors. When a drug is given by an intrathecal bolus, what happens is that it goes to the area around the tip of the catheter and then slowly moves away from that tip through convective forces in the spinal spaces. This is shown diagrammatically in the picture where a dose is seen after 0 hours, in other words, after immediate injection, and it is centered in the low lumbar area where the catheter ends. By 2 hours, the convective forces bring the dose of medicine up into the mid area of the spinal cord, and then by 4 hours it reaches the cervical area. This means that a bolus given in the lumbar area may not have a clinical effect to many hours after it's injected, and it is a reason for why patients have to be told that they can have a late effect of a change to a dose of intrathecal baclofen or to a injection of a bolus of intrathecal baclofen. Patients must be followed for a good number of hours after an injection of a bolus is given in the lumbar area. This somewhat complicated diagram is of a simulation of what one would expect from a bolus dose of lumbar intrathecal baclofen. In the upper graph, you can see in blue that the distribution over time of the concentration of baclofen immediately goes to a high level by a few minutes and then drops off rapidly with a half-life of about 90 minutes. In the graph on the lower part of the diagram, you see the spinal cord tissue level of baclofen 3 or 4 millimeters into the spinal cord tissue. You can see that that rises much more slowly and then dissipates more slowly, so that the effect is very slow even though the spinal fluid levels have already gone down. It takes time for the baclofen that has gone into the spinal cord to come out. In red shows what happens in the mid-spinal cord area at approximately T1 to T3, and in black you can see what happens in the cervical area. This again shows how the bolus dose peaks much later in the cervical area and is much lower. In fact, in most patients, only about a quarter of the concentration of baclofen is seen in the cervical area compared to the lumbar area in the steady state situation. The major advantage of using a drug pump is that it can provide medicine slowly over a long period of time. This results in a steady state condition in which the concentration of baclofen remains highest in the lumbar area and lowest distally in the cervical area, the usual ratio being about 4:1. The buildup is also safer. You can see that with the diagram showing a distribution at 1 hour, 4 hours later. You see the distribution is the same in general configuration, but there's a much higher concentration in the lumbar area as it builds up. Finally, in the steady state, which occurs after 5 to 7 hours, the distribution would stay the same. This makes the delivery much more stable over time. You do not get ups and downs due to concentration differences, and it also means that the drug is concentrated at the tip of the catheter where the spasticity needs to be treated. This diagram from the chapter shows the actual measurements that we made of material injected into the subarachnoid space in the lumbar area when a drug pump is used. We used a technetium scan in nuclear medicine techniques to measure those levels, and as you can see, the level of the radioactive dye that's being monitored in the subarachnoid space decreases along the length of the thoracic cord in a nearly linear fashion. This is what happens when the drug is given in a slow manner by constant infusion, and is the reason that the baclofen has most of its effect near the tip of the catheter, and the distribution stays the same over time. This diagram shows the importance of the placement of the catheter. The catheter is not placed in the lumbar area, but in the cervical area. The concentration of the steadily infused baclofen around the spinal cord will gradually increase and will fall off as it goes in the lumbar area and up to the brain. This can be used for spasticity in the upper extremities, and is sometimes used to deliver baclofen for states other than spasticity, such as dystonic disorders. It is important to keep in mind the difference between a bolus administration of an intrathecal drug and a constant infusion. In the first place, the distributions are quite different. A bolus distribution is more dangerous in the sense that it goes in higher concentration up to the cervical area in a way that could cause a significant side effect. The distribution with constant infusion means that the level increases in the area that you want it, in the lumbar region, and distributes only to a lesser degree into the cervical area, and therefore is safer. Also, with the bolus dose, the penetration into tissues varies. With a constant infusion, a steady state is reached where the tissue level in the spinal cord area of importance remains the same. The location of the catheter obviously determines the distribution when you have a constant infusion, and it is important to put the catheter tip where you want the highest concentration. There are a lot of local factors that change the flow and individual differences in distribution. The subarachnoid space is far from uniform from patient to patient, both because of pathology and because of individual variation in size and shape. Therefore, each time a pump is put in place with a catheter system, the patient has to be carefully tested at first to see what their responses to the medicine will be. The most important takeaway points from what I have been describing is that the regional distribution of the intrathecal medicine is extremely important. The reason why intrathecal baclofen works better than oral baclofen is not just that it gets through the blood-brain barrier, but it is distributed in the area where the abnormality caused by the changes in the nervous system that produce spasticity is. Those GABA receptors need to have drug presented to them to work. But to get the drug there requires a distribution not only by convection in the fluid around the spinal cord, but the slow diffusion of the baclofen into the spinal cord itself. These slow kinetics create a situation where you have to be very patient in deciding what the effect of the drug will be. If you give a bolus dose, you have to be aware that the bolus may reach the cervical area and cause problems in the brainstem well after the injection, as much as 3 to 5 hours later. If you give a drug by drug pump and you change the dose, effect will only build up slowly, and once again the slow distribution is a clinical phenomenon that you have to be alerted to. So the critical takeaway points are that there is a regional distribution that you must be aware of, and that the kinetics of the drug delivery are very slow. I would like to turn now to practical considerations of intrathecal drug therapy. That is, how the pump works and how the catheter system is used. This slide shows that the pumps that are now in existence have a very long survival life. And in fact, when they fail, if they fail in a safe manner. This is taken from the Medtronic's database on the Synchromed 2 pump survival, and you can see that over the 84 months that are shown, the survival rate is up to 90%. Thus, one can expect any given pump to work quite well for the duration of its battery life, which is 7 to 8 years. On the other hand, the survival of the catheter is much worse. Originally, the catheter was a simple silastic tube and was very much like shunt tubing. In that case, in the early 80s and 90s, the original catheter ran into all sorts of difficulties. And in orange, in this diagram, I show that the half-life of the catheter was about 2 years. On the other hand, the new improved catheters work much better, but still have a complication rate of up to 80% by 84 months, as shown in this diagram. This illustration shows the drug pump in its usual place and the catheter coming off of it and going into the subarachnoid space. It is threaded up to the low lumbar area, although it is perfectly all right to put the catheter in below that in the lumbar space below the end of the spinal cord, and you have good mixing in that spot also. The key areas that cause troubles for the catheter are shown in the diagram. The pump can be anchored incorrectly, and the anchors get free, and the pump can rotate and cause a loss of the catheter function due to twisting. You should always put a loop of excess catheter under the pump itself in that cavity so that there's some give and the catheter does not put a pull on the output port directly. Another area where there's frequent difficulties is making sure that the catheter is attached to the catheter that goes into the intrathecal space correctly. If it is not, it can be pulled out or twisted. It's often best to connect it to the fascia with a connector and then connect the catheter that goes into the intrathecal space. That is shown with a V-wing anchor in the diagram. There are a number of different ways to do the procedure, but after looking at the results in various centers that have had extensive experience putting in catheters, Medtronic has made a couple of recommendations about how to do the procedure. And from my experience, these steps decrease the chance that the catheter will occlude or be torn or come out. This picture is just a reminder of the type of catheter problems you can have. This occurred because the pump rotated in the pocket and made knots in the catheter, and finally the system stopped working completely. The next few slides are illustrations of ways to avoid problems when implanting catheters. In the first slide shown here, the C-arm is shown in place. It is always best to see what you're doing and make sure that the catheter that you're implanting percutaneously goes in at the right angle and is at the space that you want it to be in. The C-arm guarantees that it is done correctly, especially if you check to make sure that the fluid flowing back from the catheter is CSF and it flows back at the proper rate. The catheter should be put in an oblique manner. You see in this diagram the catheter being inserted from an angle, so that you miss the spinous processes, and that once you are into the subarachnoid space, the catheter can be advanced cephalad without any difficulty. If the catheter curls or hits something in trying to advance it, it is wise to reposition the needle and try again until you are clearly into the subarachnoid space, and then you can check to make sure with seeing whether there's adequate backflow of CSF. If there isn't, you can always put dye in to see whether the catheter is in the wrong place or whether it's a question of being a low pressure, or in worst case, a sequestered area where there is very little CSF moving back and forth. This illustration shows how the catheter should be protected before you make an incision into the skin, with the catheter being guarded by the needle. Once you've opened the area, it's important to put in an absorbable purse-string suture in the fascia to hold the catheter in place, and then whatever connector is provided with the system can be used to hold the two parts of the catheter in place in a secure fashion. Finally, this diagram is to provide a reminder that the incision in the abdomen should be away from the edge of the drug pump. The pumps themselves are quite large, the size of a hockey puck, and if the edge of the pump rubs against the incision, there's a chance of significant erosion and infection of the system. Also, you can see here the catheter being put below the pump so that there is no exerted pressure from patient movements against the outport. And the catheter is also protected against a needle hitting it when a refill is done. A number of points need to be emphasized about the clinical management of intrathecal drug pumps. The first is that one finds an enormous range in the dose that a particular patient may need compared to average patients, or the highs or the lows. That's shown in this diagram. Most patients are in the 300 to 800 microgram a day range, but some patients may be very sensitive to intrathecal baclofen, as you see in this diagram, and other patients may need quite high doses. Each patient has to be tried individually and tested, and the results of many tests over time may be necessary to get the patient into the correct range. There are a number of reasons that might affect the dosage that a patient needs. Catheter placement could be important, and the size and configuration of the spinal canal varies from patient to patient. Flow patterns of CSF are different. CSF pulsation amounts vary in different patients, as the turbulence of the fluid due to the arachnoid strands, nerve roots, and dentate ligaments also may play effect. Furthermore, there may be pathology in and around the spinal cord that affects flow. What this all means is that each patient has to be adjusted for optimal effect. A worry about the use of any intrathecal drug is that the patient will become tolerant over time. Fortunately for intrathecal baclofen, the tolerance that does occur is easily manageable and seems to stop at 12 to 24 months. So the upward adjustment in dose, as shown in this diagram, is the typical one one finds. Occasionally, there is a patient that develops true biological tolerance, and the drug has to be withdrawn and then started again. And if that doesn't work, then other drugs might be used to try to treat the spasticity, such as morphine. All patients with severe spasticity, which has been diagnosed correctly, will respond to intrathecal baclofen. That does not mean that the therapy will be useful for them or successful long term. For that to be the case, the system has to work correctly and deliver the baclofen to the right spot of the spinal cord. But if that is the case, that the baclofen is delivered, then the patients will respond. The reported benefits from the patient's point of view are as follows. First of all, there's an improvement in activities of daily living. This can include their returning to active rehabilitation, often returning to work or school because their spasms and difficulties with leg positioning are overcome once the spasticity is under control. They also may be able to improve their self-catheterization. Patients also emphasize how much more comfortable they are. It improves the amount of pain people have, although baclofen does not directly alleviate pain. It does alleviate the pain associated with the spasticity. It was a surprise to us when we began using intrathecal baclofen that the most important improvement for many patients was their improved sleep. Spasms had been interrupting their sleep and causing pain, and once that was under control, they were able to function much better during the day. Sometimes bladder function is improved. There's decreased incontinence and easier voiding, but that is not always the case, and that depends on the individual patient. Improvements such as these are very rewarding to the patient and to the doctors taking care of the patient, and that is why it has been a successful technique, but it should be used only on patients that need their severe spasticity controlled. Like any drug therapy, a number of the drug side effects have to be watched for. Unusual drowsiness is a common sign that too much of the drug has moved cephalad. If the dose is too high, it may also cause weakness in the lower extremities. Upper extremity weakness is unusual. Dizziness and lightheadedness can also occur. On rare occasions, seizures, headaches have been reported. Nausea and vomiting, primarily with bolus doses, occurs. And hypotension can occur as the lower extremities have less spasticity and more blood goes into the venous system. These adverse side effects are important to note and be aware of, and can usually be controlled by simply adjusting the drug to the patient's needs. Finally, one must be aware of the syndrome of sudden withdrawal of baclofen. This does not occur in all patients, fortunately, but when it occurs, it can be severe and life-threatening. Baclofen withdrawal can cause fever, confusion, seizures, hypertension, the severe spasticity comes back, and all of this can lead to death. The proper treatment is to give intrathecal baclofen. Before that, the patient can be managed with propofol, and the cause of the sudden withdrawal can be worked up, and the decrease in baclofen in the spinal fluid can be rapidly reversed by giving a lumbar injection of baclofen and allowing the patient then to revive slowly over time. But it is a serious problem. Patients and their caregivers should be alerted to it, and emergencies should be dealt with in the hospital as soon as possible, and the baclofen that is missing should be replaced. In some patients, when baclofen stops suddenly, there is a series of events that cause life-threatening problems. A patient can develop a fever, confusion, seizures, hypertension, and the severe spasticity that the patient has recurs. This has to be treated immediately, and the best treatment is sedation of the patient, usually using propofol, and then restoring the intrathecal baclofen. This can be done quickly with a lumbar puncture and an injection of a dose of intrathecal baclofen, and it can also be fixed more long-term by finding out what the problem in delivery is and remediating that. All the people who take care of the patient should be aware of this rare occurrence because it needs to be treated immediately. There have been a few deaths reported, and it is extremely important to treat early when this occurs to avoid severe consequences.